Hi, everyone, and welcome to the third webinar in a series that we've recorded for those who are interested in integrating the California Bridge model into their hospitals and specifically looking at what it means to do harm reduction. This webinar is on stigma reduction for emergency departments, getting really into the specifics of your setting, following two webinars that we did on the principles of harm reduction and harm reduction services, which I highly suggest you listen to. And then this is really about how you make that a reality in your space. And again, I'm Savannah O'Neill from the National Harm Reduction Coalition, and I'm joined by my colleague, Jenna Haywood. And for the third time, if you didn't remember, we're the National Harm Reduction Coalition. We're invested in the health and well-being of people who use drugs. We do that through a huge variety of strategies, from advocating for policies, developing and delivering training and technical assistance, advocating for overdose prevention and the availability of naloxone. And then we do a lot to connect and convene people, publish resources, and develop guides, all of which you can find on our website at harmreduction.org. So I wanted to start with what stigma is. I know that we've talked about it in our previous webinars. It's something that we hear about a lot, that medical professions and emergency departments and hospitals and medical schools discuss. But I want to give a little bit of framing about how we think about it here and what that means about your actions. So stigma is not just discrimination, right? So this is a visual that really shows that it's a social process that is linked to power and control. And it leads when there are beliefs and ideas about people that deviate from being in the norm, or when people behave badly. And then it creates social conditions that make people feel like people are not deserving of being treated with dignity and respect, and actually creating structural and social discriminatory actions that cause people harm because of the things we believe about them. And so because of how that structure functions, stigma really limits people's ability to access services, both internally, because maybe they don't believe they're worthy of requesting services, or that there is something that could actually support them. And it also creates barriers because people might feel judged, and we might be enacting stigmatizing barriers either structurally through funding, how we fund certain medical care, or, different hiring policies that show that we don't believe that people who use drugs might be worthy of being in our community. So how that works visually, I really like this visual example, is that we have ideas, right? So that, as I was saying, someone who uses drugs or someone with a substance use disorder is not trustworthy, right? That they steal. That's the idea, maybe. Or here, they're incapable, fragile, can't recover. These are ideas we hear about people, if you can just think about how we hear about people with substance use disorders. And so then that starts to form into a belief. And these are things that could happen when we're really young, and we all carry stigma. So maybe that belief becomes, if people who have substance use disorders lie or steal, that then they're untrustworthy. So our belief about them is that they're untrustworthy. And how this deviates from just a stereotype or a negative belief is that it actually translates into an action that carries power, that the person who's being stigmatized loses power. So if we believe that they are not trustworthy, what are our actions socially? If someone's not trustworthy, you don't want them to be your coworker. You don't want them to be your roommate or marry into your family, right? Because we have these ideas that that person's not trustworthy. That also gets codified into our structures. So if we think someone's not trustworthy, we might not want to give them medications without a urine screen, because we're saying, nope, I don't trust that you're going to tell me the truth. We might not want to hire people and create barriers and, drug-free workplace, create drug testing for low-wage work, and other kinds of, needing to have someone not have a criminal record. All those things are kind of structures that say, yeah, we don't trust you, so we don't want you in these positions. And that can happen. You can kind of use any idea or belief and follow it to the discriminatory actions. And that's how we see stigma really start to harm people. And so now we're looking at what we do maybe in smaller ways than those big structures I was talking about, and thinking about language. So the language we use, you might have noticed I'm using words like people who use drugs, person with a substance use disorder. And I do that because I'm trying to not invoke stigma through some other language people might use. So why does this matter? Does language really affect stigma? So yes, it does is the short answer. And I pulled up a bunch of studies here for you that show what the impact of language is. So we'll go through kind of like what are the preferred words after this, but we know that for clinicians, if you look at things like substance use disorder versus substance abuse, for example, that studies show that even super trained clinicians will enact more punitive responses or punitive medical care when you say substance abuser than when you say substance use disorder, or a person with a substance use disorder, using person first language to make sure we humanize people. And you can see their negative attitudes among health professionals have been found to adversely affect the quality of care and treatment outcomes. So when we're using even a word like abuse and seeing it as something that isn't rooted in being harmful, it's the language you came up around, it's what you've known, actually does shape our ideas about people. It creates negative judgments and punishments because the word abuse is perceived that way culturally. So we see this in a bunch of ways. And so this isn't only for medical providers, it's also for media and other spaces. And so even the APA style book instructs journalists, right? So these are the people who say, hey, here's how you should write about drug use. In 2017, they said, hey, stop using the words abuse and problem and start using things like use with a qualifier, which we're going to talk about, risky use, excessive use. And they shared this, which I think is a really salient quote. These changes aren't merely semantics or political correctness. Widespread media misunderstanding of the fundamental nature of addiction has led to some deadly misconceptions about how it should be managed. So we don't change our language only because it feels good or is the newest way to ensure you're being kind to people or, being politically correct. It actually deeply affects how people's receive care, their treatment outcomes, and the way our whole structures are developed to treat people. And so that's why a lot of people have really recommended the adoption of non-clinical, non-stigmatizing language for substance use, both to shift the individual interactions as well as the structural.
And so you might be asking yourself now, okay, so these are the words that I've been using. Well, what is the word that I should be using instead? What is the language we should be using? Of course, none of us want to go out and stigmatize somebody, and we know that drug use is actually one of the most highly stigmatized behaviors that exists. So people who use drugs experience a ton of stigma, and that's often compounded by other stigmatizing groups that they might belong to. So we use person first language, like you've just heard Savannah modeling, and no one is going to have this, perfect in after one webinar. It takes practice, and we're going to talk about that. And also, I think it's important to remember that you might not hear people you work with use person first language about themselves, and that doesn't mean that it's not important for you to use it when you're talking about them, and especially like Savannah mentioned, when we're writing in charts or making, officially documenting somebody's situation. So terms not to use over on the left include things like addict, abuser, junkie, druggie, alcoholic, drunk. Um, it also applies to clean and dirty. So when you're talking about urine analysis, for example, um, it should be a positive urine screen versus a dirty urine screen, or a clean a negative urine screen versus a clean urine screen. And so what that obviously terms like clean and dirty are associated with, have really strong associations um, with them. And so being mindful of all of the different ways that you might be using that kind of language. The same with addictions, addictive disorders, and so really the term is substance use disorder, or to be as specific as possible, and we'll get into that as well. So talking about someone, a person with substance use disorder, a person with opioid use disorder, a person in recovery. Um, and the reason for person first language is that a person is a person first, and a behavior is something that can be changed. So always grounding in the humanity of a person, and not putting a label on them that essentializes them, or puts them into a box, or places an identity on them that they may not hold for themselves. And if they do, and they say, yeah, actually, I use addict for myself, and that's important to me, that can be on an individual basis, but not something that we should create systems around. So along the same lines with how the language we're using to talk about people who use drugs is also what is the language we're using to talk about drugs themselves. And this tool here can be really helpful for expanding the way that we talk about drug use. And you can see that this is a spectrum, and the arrows point in both directions. And the reason for that is that it really allows for people to and for us to think about people who use drugs um, as something that can change, and it can go in either direction, and and that um, and that there's nuance to substance use, and there may be nuance to the substance use to substances themselves that a person uses. So, for example, somebody may identify as abstinent from opioids, but they still smoke weed or drink alcohol socially. Somebody may uh, have do regular use of opioids, and then ritually binge or experiment with meth, for example. So what we know is that, yeah, substance use is complicated, and so when we limit the words to either abstinent or an addict, if those are the only two words that we have, you're either sober or you're an addict. We really miss the opportunity to practice the principles of harm reduction and really meet people where they're at with their using. So this can be a helpful tool for us to learn about different kinds of use, but also um, to ask clients or patients when you're working with them to look at the scale themselves, and tell us, where do you fall on the scale, and where would you like to see yourself, so that you can work together with them to use language that's most appropriate to their experience. And so, are you using sensational or fear-based language? So what we know is that a lot of people get their drug education from the media, from movies. Maybe it was from the DARE program that was just about just say no. And so by no, with good intentions, I think we can all fall into using sensationalized language to talk about drugs. And often this is, again, really can be rooted in stigma that goes beyond just people who use drugs, but also stigma about um, that is really embedded in racism, right? So when we think about the history of the war on drugs, and the history of some of programs like DARE, they are really rooted in um, this sensationalizing of some drugs and not of others. And so um, when we, being mindful to talk about um, words like, you know, uh, here on the left, you see like America's heroin epidemic is being overtaken by another deadly drug addiction, fentanyl. And we've now heard, people talk about like fentanyl is in, it's being found in marijuana, it's being found in cocaine and not really necessarily taking the time to dig into some of the headlines that we might see, to get the facts and to get the evidence on how we should be talking about the dangers associated with drugs. On the bottom, it's talking about words like zombie drug or fighting the demon up at the top. When we see these ads that are really hyper, you know, they're really extreme in the way that they portray drugs, and that just isn't the reality, and it's also not something that generally people you're working with are going to relate to. We know that a lot of times media images and headlines are not created by people who have lived experience with drug use, and so it has the effect of isolating and further stigmatizing people who use drugs. So just thinking about that when you hear headlines come up and when you're talking to people you're working with. And so in this next section, Savannah is going to break down a little bit what are some steps that you can take in your hospital. And in our last webinar, we really talked about different harm reduction services that you should definitely check out, because there are tips in there as well about what harm reduction services you can implement into your hospital in terms of connecting to what's going on in your community and how you can really create the best possible care for people who are coming in. But Savannah's going to walk us through looking at what steps you can take to really look at your language and how you're and intervene on any stigma that might be happening unintentionally in your setting.
Okay, so yeah, we're going to get into some next steps. So what I have learned in my years of working with medical providers, and what everyone always tells me, is people like concrete action steps and like things that are very implementable and tangible. And so I know we've talked about a lot of ideas which really inform these things, but we also wanted to leave you with concrete action. So there's the institutional level. So I would say if you're someone who's a hospital administrator, you're someone who is a champion or a lead in your emergency department, you have some power. These are things to institute at the institutional level to really change what that looks like. So the first, hiring staff dedicated to navigating people with substance use disorders to care and within care systems. So we've seen this roll out with the California Bridge program and substance use navigators. It's also a core part of HIV care to have someone actually navigate people through systems. And one of those reasons is because of stigma, because of all the things that get built up around medical care. We really need someone to create safety and to interrupt that pattern of how people experience medical care. Even if everything we do inside our setting is going to be really kind, people come with that baggage. And you ideally want to hire someone with a lived experience of substance use, someone who can relate to the community, who can share that perspective and really understands and brings the insight into why that kind of connection is so important. And really value that as experience. Then you also want to perform a language audit of your existing materials. So we have really liked this because it's something that often people don't take the time to do. But if you think about all of the things that we just talked about in this webinar, what of the language that we discussed as being not the most ideal and possibly stigmatizing still exists in your forms, your brochures, and your signs? Sometimes that stuff sits on people's desks for years, for decades, and we don't think to change it. And how do we just do a whole audit and replace it with inclusive language and the power that that has institutionally? And we saw in the impact of stigma that stuff actually matters. If you chart in your notes substance abuse or, abusing methamphetamine, that impacts how that person is treated forever in their medical chart. So how do we change our electronic medical records, our forms, to really be more inclusive and use language that is more supportive? And that creates better outcomes for our patients, even past their time of seeing us. And then if you're developing new materials or programming, if you're integrating a new program, developing new materials, really seek input from stakeholders and seek it from the people you're trying to reach, people who use drugs. You're trying to create a poster to tell them about the fact that you're doing buprenorphine in your emergency department. Who you need to ask is people who might seek that from your emergency department, and what do they want to see? What speaks to them? What's the language that's important? And host a focus group. Ask people through your clinical rounds, like whatever way you can to get that input. And then offer consistent and ongoing trainings at all levels with an all-some approach. So what this means is there's some training that all staff need, from your security guard, your parking lot attendant, your receptionist. Everyone needs to understand what stigma, how it operates to some extent, and how those interactions really shape people's experience. And then some people who are maybe providing the substance use care or working in the emergency department need a deeper training. And so really offering consistent training at both those levels. And then if we're looking at the next individual action, so maybe you're not someone in your hospital who has power to enact institutional change. That doesn't mean you can't still start to shift these things in your hospital. So the first is working on your own language. Practice with your colleagues, choose an accountability buddy to offer feedback. Maybe there's been a word that I've tried to work on out of my vocabulary that definitely has happened. And I asked Jenna, who works with me really closely, hey, when I say that word, could you just remind me that I'm trying not to say it? So that when she does that, it doesn't feel aggressive to me. It's a reminder that I'm trying to work on something. So that kind of accountability ahead of time can help reduce some of the shame we feel when someone might call us out on our language. Practice with your colleagues, think about how you can do that differently, and just continue to do that work. And that goes into the last point, which is stay teachable, be open to changing, follow reputable sources for information, and we can give you some access to those, and be open to your own ongoing growth and change, which is really challenging. We get really inundated with information, and how do we make sure we're staying open to how things might change and evolve? And if there is feedback regarding stigmatizing interactions from patients, make sure you relay them, tell people about them to your supervisor or hospital administrators. Like, people sharing that with you shows that they trust you, and make sure that their complaints about how they're being treated are taken seriously. And if you're not able to host focus groups or get input at that level, you can still seek input from people with lived experience in your one-on-one patient interactions. Ask them what's working for them and what isn't. Make space for them to be heard, and then integrate and change your practice. So those are really all things you can do. We'll make sure these are accessible so you can reference back to what these are. But we just ask that people take on whatever level you can to create safer spaces and more accessible spaces to people who use drugs.
And thank you so much. And just to wrap up, I think one last point is just, when we remember that people who use drugs are the number one most stigmatized group of people, we can remember that likely people who are coming into access care are really being treated poorly in every area of their life. And so you have an opportunity to maybe be that one point of contact that actually asks them about their experience and expertise, and lifts up them as being as having autonomy around their own life and well-being, and values them just the way they are, and really truly aims to meet them where they're at. So thank you all so much, and please reach out to us if you have any questions or would like more information or training. You can reach us through our website, harmreduction.org.